This conference will now be recorded.
Department of Ophthalmology, Sheikh Zayed Hospital, in today's clinical meeting. Uh, to start the proceedings, I would like to call Dr. Hasib, our training registrar, to recite few verses from Holy Quran. أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. سبحان ربك رب العزة عما يصفون وسلام على المرسلين والحمد لله رب العالمين. صدق الله العظيم. Now we request Dr. Khwaja Khalid Shoaib for his welcoming uh, words on the behalf of OSP Lahore.
Assalamu alaikum. I am Dr. Khwaja Khalid Shoaib from Mughal Eye Hospital. I am Joint Secretary of the OSP Lahore. So it is heartening to see so many people present here for this academic activity. I will remind you that we are going to have a mock FCPX examination on 24th and 25th in Mughal Eye Hospital for those who are appearing in the FCPS Viva, who have passed the theory paper. And we will have this next meeting, OSP meeting in Services Hospital after 1 month. So it is good to have discussion of the cases, but as we were discussing with Professor Atif, that it is best to examine the cases before the presentations to have your own assessment. So we'll improve this culture and we will bring back the examination of the patients before the presentations. So this culture will be promoted inshallah next time. So we can start with the presentation.
I will call on Dr. Iram Abbas, Assistant Professor of Ophthalmology, Sheikh Zayed Hospital, to moderate the session.
Assalamualaikum everyone. I'm Dr. Iram working as assistant professor in the Department of Ophthalmology in Sheikh Zayed Hospital. So to present with our first case, I would like to call Dr. Noor Tariq. Assalamualaikum. My name is Dr. Noor Tariq. I am a postgraduate resident of ophthalmology in Sheikh Zayed Hospital. Today I am here to present a case presentation with a unique topic titled Wolf in Sheep's Clothing, a rare ocular manifestation. We had a young 16-year-old girl presenting into our OPD on 13th of April 2023 with the complaints of decrease in vision in left eye, protrusion of the left eyeball and redness in the left eye for 2 weeks, and swelling of the left side of skull for 2 months. History of presenting illness. Patient was in usual state of ocular health 2 weeks back when her parents started noticing the bulging of her left eye, which was gradual in onset, painless in nature, and progressive. Sneezing, coughing, and changing posture had no effect on the protrusion of the eye, and patient also complained of altered perception of colors. After 1 week of protrusion of the left eye, patient started developing a loss in vision, which progressed rapidly, beginning from blurring of central vision and leading to complete visual loss. She also complained of complete inability to move or completely close her left eye. Swelling was present on the left side of the skull, which was given a history for past 2 months. There was no history of weight loss, tremors, or heat or cold intolerance. In the past history, patient was in usual state of health in 2018 when she first developed pain in her left leg. for which she was treated initially with multivitamins and supplements by a local physician. However, when her condition did not improve, she went to the orthopedic department of a trust hospital in Lahore, where she was advised CT scan of left leg, which suggested osteomyelitis of the tibia, and she was treated on the lines of chronic granulomatous inflammation. This is the CT scan of the left leg, which is suggestive of osteomyelitis of tibia. However, her condition did not improve, and MRI left leg was done, which showed an osteogenic mass. Biopsy of the tibia was done, which showed Ewing sarcoma in January 2020. And amputation of the proximal tibia was done in June of 2020. The initial CT chest and pelvis was done in 2020, which showed no metastasis. And there was a loss of follow-up by the patient in 2021. In 2022, chest CT was done again, which showed pulmonary metastasis. Here we can see that patients showed pulmonary metastasis. The family history and personal history were unremarkable. Now coming to the general physical examination, we had a thin, lean, emaciated young girl sitting uncomfortably in a wheelchair, well oriented in time, place, and person, and cooperative in the examination. Her vitals were within the normal limits. On the general physical examination, there was a large solid mass in left temporal region of the skull, measuring about 5 into 4 inches in size, which was painless, non-tender, and was gradually increasing in size. This is the patient of the picture, which was taken with the consent of the patient and her parents. As you can see, there is a large swelling on the left side of the skull. The systemic examination was unremarkable, and the investigations done prior to visiting Sheikh Zayed Hospital were as follows. Patient showed low levels of HP. She had hyponatremia. Her alkaline phosphatase levels were rising rapidly. As you can see in this, her alkaline phosphatase level is 454, which is in the with the high ranges. Her CRP was negative, and THCV was negative. This is the biopsy of the patient showing chronic granulomatous inflammation, and this is the biopsy of the left proximal tibia showing Ewing sarcoma. Now, ocular examination was done at Sheikh Zayed Hospital for the loss of vision and proptosis. This is a picture of the patient with the left eye. The visual acuity in right eye was 6/9, while in that of left eye was no perception of light. The extraocular movements were full in the right eye, while there was complete ophthalmoplegia, external and internal, in the left eye. The interior segment examination of the left eye showed inferior corneal ulcer due to exposure keratopathy, and the pupil was dilated, non-reactive. The left disc showed pallor. Color vision and visual fields of the left eye were within the normal limits, but for the left eye, color vision and visual fields could not be done because of no vision. On Hertel's ophthalmometer, the left eye measured about 24 millimeter and the right eye measured 18 millimeter, showing a difference of 16 millimeter between the both eyes. 6 millimeter, sorry. The proptosis was non-axial with a dystopia of 4 millimeter inferiorly and 3 millimeter temporally. There was no lid lag or lid retraction. No retropulsion, pulsation, or bruit was heard. On performing double serval maneuver, there was no change in the orbital bulging. Orbital margins were intact, and the regional submandibular and sublingual lymph nodes were not palpable. Now coming to the differential diagnosis. Differential diagnosis was made with orbital metastatic disease, orbital cellulitis, and idiopathic orbital inflammatory disease. Investigations advised were MRI brain with an orbit with contrast. These are the MRI scans of the patient, which showed multifocal marrow replacement involving calvarium, left orbit, and sphenoid sinuses with large soft tissue mass components suggesting of a metastatic disease. If we look closely to the MRI scans of the patient, we can see that there is a soft tissue is present on the left side intraorbitally. and the left orbit with superior orbital bone is involving and superior rectus muscle is compressing and hence displacing the orbit infratemporally. Now, if we look at the skull, the soft tissue is extending into the scalp and intracranially but not involving the parenchyma. The right sphenoidal sinus is also involved, which is compressing the cavernous sinus. Hence, the diagnosis was made Ewing sarcoma with orbital metastasis. As we all know, Ewing sarcoma is a very rare carcinoma with a prevalence of less than 2% overall, while with the orbital metastasis is even rarer, accounting for 2% of the all metastatic diseases. So no much of the clinical data was present, and the case studies we can find internationally were some of the publications we found were by Lupin Publishers, which was done in 2018 with the title A Metastatic Tumor of Ewing Sarcoma in the Orbit. And the other one was done in International Journal of Scientific Research in November of 2018 with the topic Orbital Metastasis in Ewing Sarcoma, a Rare Cause of Proptosis. This is the prevalence rate of Ewing sarcoma, less than 2%. These are the references. And what is the take-home message for this case presentation? That orbital metastasis should be considered in the differential diagnosis of patients with proptosis and periorbital edema. Proptosis due to metastasis from Ewing sarcoma can occur early and may even be the first presenting sign. Thank you.
Very well presented, excellent case. So, have you done any intervention, any by neurosurgeon for removing this mass? Is there any planning to go ahead with the removal of this mass?
Actually, the patient was referred from emergency. They were planning to have a tumor. And they were trying to have a tumor. So, उन्होंने बोला कि tumor section की जो सके बाहर was referred for two operations.
That is a good case for
Thank you.
publication also.
Yes, sir.
मेरे लिए local reference नहीं है और international नहीं है चार्ज करूँ दूसरा इसलिए isolated लेके आई सर ये कुछ
थोड़ा हिम्मत करें और
जी सर, we are Inshallah.
ये प्यार है
good documented.
Thank
Well
you, sir.
done.
Thank you. To present the second case, I would like to call Dr. Khadija Junaid.
Assalamu alaikum everyone, I'm Dr. Khadija Junaid and I will be presenting an interesting case related to the ocular side effects of COVID-19 vaccination. Bismillahirrahmanirrahim. 22-year-old female medical student resident of Sargodha presented to Sheikh Zayed Hospital IOPD on 12th May with the presenting complaints of bilateral redness, photophobia, blurred near vision, and unequal size of pupils. The symptoms were present for 1 day before presentation to the OPD. The history of presenting illness revealed that the symptoms were gradual in onset, progressive in nature, and symmetrical bilaterally. They were aggravated by bright sudden light and relieved by coming in a dark or a dull room. No history of ptosis, diplopia, fatigability, or any dysautonomic symptoms were noticed. The past history involved a visit to the emergency with a fever of 102 Fahrenheit, which developed 2 days after her first COVID vaccination dose, which was injected on the 28th of April, and the ocular complaints developed 2 weeks after the first COVID vaccination dose. The fever was associated with vaccination, and tablet dexamethasone and moxifloxacin were given for 2 weeks, along with some antipyretics, which improved the situation of the patient. Surgical and family histories were unremarkable. My patient belonged to a middle class family and a history of seasonal allergies was present. On general physical examination, a young female with normal build, normal breathing pattern, sitting comfortably, well oriented in time, place, and person, who was cooperative during the examination. The vitals were normal and the patient was afebrile at the time of examination. The cardiovascular, respiratory, and abdominal examinations were also unremarkable, and so was the central nervous system. We performed motor, sensory, cranial nerve, and cerebellar signs as well to rule out any other causes. The ocular examination was divided into external ocular, anterior segment, and posterior segment examinations. The visual acuity was 6 by 18 and 6 by 36 respectively in the right and left eyes, which improved to 6 by 6 with glasses and pinhole. The intraocular pressure was normal, the extraocular movements were full with normal convergence, and the color vision was normal as well. In the anterior segment examination, the pupils were fixed and dilated. The rest of it was unremarkable. The posterior segment examination was also unremarkable, and the fundus was within normal limits. On the pupillary examination, a vertical pupillary diameter of 6 mm and 5 mm was measured in the right and left eye respectively. The pupils were dilated, non-reactive to light. However, they were sluggishly reactive to near reflex. The border was normal and no sign of any trauma was noticed. The test for light-near dissociation was also performed, in which the pupils were unresponsive to light but slowly reactive to accommodation. The pupils dilated slowly after the removal of the near target. On the basis of history and examination, the following differential diagnoses were made, namely Aedes pupil, viral infection, pharmacological dilatation, diabetes mellitus, multiple sclerosis, and brainstem lesions, namely the Perrinaud syndrome. Investigations were performed, which included the MRI brain, which came out normal, and a COVID-19 PCR performed via a nasopharyngeal swab was also negative. As we can see an MRI report of the brain showing that it's normal. On 8th June 2021, a pilocarpine test was performed, in which a weak pilocarpine solution of 0.1% strength was instilled in the form of eye drops bilaterally. The dilatation of the pupils improved and myopia was induced. This test uses 0.1% pilocarpine, which is weak pilocarpine, to distinguish a normal pupil from an Aedes pupil. An Aedes pupil in this scenario is going to constrict significantly after 30 to 45 minutes. On the basis of history, examination, and investigations, a diagnosis of post-COVID-19 vaccination Aedes tonic pupil was made, which is a very rare presentation. For the management, symptomatic treatment for conjunctivitis was given, dark glasses were advised on exposure to bright light, weak pilocarpine solution was given once a day, regular follow-up, and reassurance was advised to the patient. In the most recent follow-up, which was in the month of May 2023, pilocarpine was advised as the patient had not been compliant in the past. The symptoms in pupil size had improved over time. This is a picture of 2021 posted with my patient's consent, which shows fixed dilated bilateral pupils, and this shows slight improvement in the pupil size and her symptoms. The only case report found on the internet was the Aedes pupil after mRNA COVID-19 vaccination in the American Journal of Neuro-Ophthalmology, published in July 2022. Most of the case reports were related to Aedes pupil during active COVID infection or Aedes pupil post-COVID infection. We will definitely be publishing a report on this topic, inshallah. Thank you so much.
सर एक पॉइंट ये था कि ये जो रिपोर्ट पब्लिश हुई है दैट वाज मैसेंजर आरएनए वैक्सीन जो ये साइन है which contains COVID-19 जो यूज किया बाय द गवर्नमेंट PCR नेगेटिव था तो प्रीवियस हिस्ट्री थी इसकी कोविड की लेकिन ये वैक्सीनेशन से 2 वीक एंटीबॉडी टाइटर्स जी वो पीछे उसके बाद भी कुछ टाइटर्स चेक नहीं हो रहा था पीसीआर ही कराया पीसीआर खाली वो पीसीआर वाज नेगेटिव वो कई बार नेगेटिव पॉजिटिव हो जाता है ना वैक्सीन लगाते हैं तो नेगेटिव का मतलब क्या उसका पास भी पड़ा है नहीं पड़ा इसको Sinovac.
The symptoms improve.
Sinovac.
The signs भी improve हो गए.
जी बताइए. फेब्राइल इलनेस इमीडिएटली आफ्टर नेक्स्ट डे से आएगी या ईआर रूम में आ गई फिर उसके बाद फिर ये कोई 2 वीक के बाद फोटोफोलियो कोविड हो सकता है लेकिन जनरली इसको फोटोफोबिया या नियर वीएन पे इस तरह का कोई इशू कोविड इन्फेक्शन के बाद उसकी कोई हिस्ट्री ऐसी नहीं है. वो 6 to 8 months बिफोर दैट वैक्सीनेशन he recovered well. There are process to be some other courses like that will come to that. So this time जब ये हुआ था तो immediately last बेहतर हो गया पर अभी ऑलमोस्ट 50 to 60% वो जो नॉर्मल रिकवरी है मैनेजर को मैं
Less content. Okay, for the next case, I would like to call Dr. Moalla.
दोनों की एज 82.5 विदाउट एनीथिंग एक को तो काफी इमीडिएटली मिल जाता है.
Bismillahirrahmanirrahim. Assalamu alaikum. My name is Dr. Moilla. I am first year resident of ophthalmology at Sheikh Zayed Hospital Lahore. Today I'll be presenting a case related to complication of LASIK, post-LASIK complication. It is a rare complication. It's not reported nationally. However, it is reported internationally. A 25-year-old man came to IOPD on 21st March 2023 with following presenting complaints: inward deviation of both eyes from 1.5 months, blurring of vision, occasionally mild headaches from 1 month, and double vision on and off. Moving on to history of presenting illness, patient presented to OPD with complaints of sudden onset inward deviation of both eyes 1.5 month after LASIK. According to him, the symptoms started soon after the LASIK procedure. The deviation was associated with double vision, which was gradual in onset, binocular, intermittent, and more for distant vision. It was also associated with mild headaches. Headaches were also gradual in onset, frontal in nature, intermittent, and there were no aggravating or relieving factors. There was no history of any fever, febrile illness, any history of head trauma, however, whatsoever. His past medical history and past history of drugs, surgical, family, and personal history was all unremarkable. However, his past ocular history was significant. The patient was a known hyperopic. He was using plus 3 cylinder sphere in right eye and plus 3.5 sphere in left eye, for which he went for uncomplicated LASIK 1.5 months ago. There was no history of deviation of eyes or diplopia before the procedure, and he was using glasses which he was comfortable with. Moving on to examination, he underwent general physical examination, systemic, and then ocular examination. General physical examination showed an average built sitting patient comfortably in chair, well oriented in time, place, and person. He was cooperative during history and examination, and his all vitals were within normal limits. Um, Moving on to other examination, all were within normal limits or unremarkable. Systemic examination was also unremarkable. His anterior and posterior segment examination was all within normal limits, including the pupils, which were round, regular, reactive on initial presentation. His visual refractive status was, however different. His visual acuity was 6 by 9 in right eye and 6 by 12 in left eye. He was improving to 6 by 6 in both eyes with pinhole. However, he presented with pseudomyopia. He was improving to 6 by 6 with -2 sphere in right eye and -3 sphere in left eye. We moved on to cycloplegic refraction, which showed a refractive error plus 1.5 in right eye and plus 1 sphere in left eye. His color vision was normal and intraocular pressure was within normal limits. Moving on to further examination, he was having intermittent diplopia of varying degree, which was worse on distance. Hirschberg test showed 35 to 40-degree esotropia in both eyes. Extraocular movement showed his versions were shows limited abduction of both eyes. However, his ductions were normal. On cover test, cover test showed alternating convergent strabismus with limited abduction of both eyes. There was no third nerve, third, fourth, or sixth cranial nerve paralysis or paralysis because he was able to move his eyes laterally when his eyes was tested separately. This is the initial presentation and picture of the patient. All the pictures are posted with consent after taking consent from the patient. Investigation, and he underwent following investigation: head charting and neuroimaging. CT brain and MRI were within all normal limits. His head chart showed this presentation. His head chart showed overaction of medial recti and underaction of lateral recti. Bilateral lateral rectus underaction and medial rectus overaction. All of this, owing to this presentation of head chart, we made the diagnosis of spasm of near reflex. Also, his differential diagnosis include post-LASIK spasm of near reflex, bilateral sixth nerve palsy, bilateral Duane syndrome type 1. After careful history, examination, and previous past history, we made the diagnosis of post-LASIK spasm of near reflex. He was treated with cyclopin eye drops 1% at night, which was later discontinued because of photophobia. He was also prescribed spectacles, which helped him improve asthmatic symptoms soon after we prescribed them. His squint and diplopia, however, improved over the course of 2 months. The near reflex, LASIK is a very common procedure nowadays, but there are not many complications that are reported. The near reflex is the action of eye for adjustment to fixate on a near object. This reflex includes triad of three things: accommodation, convergence, and meiosis. Spasm of near reflex is when this triad persists, but not for near, but also when the patient is not fixating on a near object. Patient will present with blurred vision, diplopia, astenopic symptoms, and on examination often have an alternating convergent strabismus, abduction deficit, and pseudomyopia. Our patient have all of these symptoms. SNR can be primary or acquired. It is, however, more common in females, and it's psychogenic in nature. It can also be because of uncorrected hypermetropia, which we think is the probable cause in our patient. These are the references. All of these references were found internationally. The first two references were in 2006 and 2007 in American Journal, and the last two were case reports on spasm of near reflex. These are the expanded version of these. So the take-home message is whenever we are planning for LASIK, we should always do cycloplegic resection because there could be an accommodative spasm after the after LASIK. Accommodative spasm should be considered in patient undergoing hyperopic LASIK surgery, which can be complicated with fluctuating refraction of uncertain causes. Whenever the patient presents with history of episodic diplopia with normal conjugate eye movements and intermittent blurred vision, it is always suggestive of spasm of near reflex. So you should always rule out that. Thank you so much. Any questions? नो जब हमने अबडक्शन की थी तो उसमें हमें माइल्ड मायोसिस फील हुई थी बट वी वन श्योर सो हमने उसको नहीं डाला उसका साइज वगैरह हमने नहीं देखा क्योंकि इट वाज ऑल हमेशा वो जब भी हमने किया वो अबडक्शन में आ रही थी तो इट वाज डिफिकल्ट टू मतलब यस +3 इन राइट वो लेसी का डाटा तो बेहतर हो जाता स्क्रीन 2 मंथ्स में बेहतर हो जाता
The most effective error था इस cycle.
सर ग्लासेस में हमने साइक्लोपेजी करने के बाद +1.5 राइट में था एंड +1 लेफ्ट में था फिर हमने सर वो लगा नहीं रहा
Sir, वो क्योंकि उसका pseudo myopia because of the combination spasm था, तो that was the refractive error without cyclopedia.
यस सर ओवर 2 मंथ्स वो इम्प्रूव हो गए थे
And it is decreasing.
सर +1.5 इन राइट आई एंड +1 इन लेफ्ट आई स्टार्ट हमने यहाँ से किया था ताकि उसकी अकोमोडेशन बिल्कुल रिलैक्स हो एंड देन हमने 2 मंथ्स बाद इसको थोड़ा सा डिक्रीज करके किया था 0.5 पे काइंड ऑफ यस सर हमें साइक्लोपेजी को अकोमोडेशन का
Hypermetropic
हमेशा
means
रखना
to do cyclopedic diffraction prior to LASIK and to determine the true refractive error.
चाहिए नहीं सर उसमें तो
Cyclopic है.
जी सर यस सर
So they are not very happy. In contrast, in myopia, because the number is fixed, so they are very happy. So these are difficult patients to start with. Hypermetropic patients, on the whole, are unhappy. Whether you do give them refractive glasses, you give them contact lenses, you do laser on them. Reason being, their accommodation is always not as accurate and as good as it is those who are myopic and anyway, definitely those who are hematopic. So the in my opinion, the lesson to learn is do not try to correct hypermetropia with a dimer or whatever you want to do. And even giving them glasses, do not try to make them to see 6-6. If they are happy with 6-9, leave them there. But somehow or other, they are always unhappy. Their mechanism probably does not work as accurately as another one. But some of them, they are very happy. I think the refractive lens is saying they are happier patients compared to the other ones.
I think because of the nature of surgery, in hypermetropia, you do a peripheral thinning, or you use central steepening. In myopia, you actually shave off these. So the peripheral thinning that you do in hypermetropia actually has a regression over a period of time. So hypermetropia tends to come back uh, maybe 2 to 3 years after elective surgery. One of the reasons for the hypermetropia coming back. Maybe it has to do with aggressive wound healing in some of patients, so that the peripheral thinning that you do actually wears off, or something like that.
And sometimes corneas are also converted to tropias after the refractive surgery. This should also be kept in mind.
Thank you so much.
To present the last case, I would like to call Dr. Noor Fatima. Assalamu alaikum everyone. This is Dr. Noor Fatima and I'll be presenting the last case for today. So let's start. So a 15-year-old female student who was unmarried resident of Lahore presented to us on 13th April 2022 in our OPD with the presenting complaint of sudden and painless loss of vision in her left eye one night before presentation. So, on probing on her history of presenting illness, the patient was in usual state of health one night before when she noticed loss of vision while studying. It was acute, it was sudden, painless loss of monocular vision in her left eye and not associated with any other symptom like headache, vomiting, nausea, and nothing like that. So, on her past ocular history, there was no use of spectacles or any ocular trauma or any such thing before this. Her past medical history was also unremarkable, so was her surgical, gynecologic, and personal history. She basically belonged to a middle class family. During her general physical examination, we saw a thin and lean young girl sitting upright in her chair who was well oriented in time, place, and person, understanding and responding to our commands. She was vitally stable. There were no rashes, no joint swelling, no temporal or scalp tenderness noted. Now, on her ocular examination, the visual acuity in her right eye was 6 by 6, whereas in her left eye it was hand movement, and there was absolutely no improvement with pinhole or with refraction. The intraocular pressure bilaterally was within normal limits, and her extraocular movements were full. During our anterior segment examination, bilateral corneas were clear. The right pupil was round, reactive, and regular, whereas the left pupil showed a grade 3 relative afferent pupillary defect. The pupil dilated immediately. The anterior chamber was quiet, the lens was normal, and so was the adnexa. During our posterior segment examination, the right fundus was normal, whereas the left fundus showed a pale disc, and the macula showed a focal area of well demarcated retinal edema, which was centered on the macula and it extended to the disc. The peripheral fundus in both the right and left was unremarkable. Now, this is a fundus photograph which shows retinal whitening or edema centered on the macula and it extends to the optic disc. Unfortunately, we were not able to perform the color vision of the patient nor visual fields because the patient had hand movement and poor vision generally. So, in tandem with the neurology department, we performed her neurological examination, which included higher mental functions, memory, speech, all the cranial nerves were examined, and the signs of meningeal irritation were also noted, but everything was negative. So, according to this history and the examination done, we arrive at a differential diagnosis of cilioretinal artery occlusion, central retinal artery occlusion, or branch retinal artery occlusion. So, during our initial management, we performed ocular massage for the patient, which was done with a contact lens, and then injection mannitol IV stat was given to the patient, 200 mg over 20 minutes. The patient was also prescribed topical dorzolamide eye drops in twice daily dosage, and she was also given tablet clopidogrel and aspirin 75 mg once daily. A list of investigations was done for this patient as we wanted to rule out any immunological or rheumatological cause or any autoimmune or vasculitis related problem. And we had to make sure there was no systemic abnormality noted. So protein S, protein C, antithrombin 3, complement levels, CRP levels, all were done by the rheumatology department. This was followed by all the autoimmune profile, anti-smooth muscle antibody, anti-mitochondrial antibody, RF factors, factor 5 and all of these were noted to be normal. Her routine baseline investigations were also normal and within normal limits. Now, to rule out any other causes and any other systemic abnormalities, echo was done, Doppler study was normal, EEG was also normal. During our ocular investigations, we also did fundus fluorescein angiography, and we saw slow filling of the left cilioretinal artery, and it was prolonged to the venous phase. Now, technically, cilioretinal artery has to fill during the choroidal phase as it arises from the short posterior ciliary artery, but here it revealed a occluded cilioretinal artery, and the filling was prolonged to the venous phase. This is a picture of the fundus fluorescein angiography in the arteriovenous phase, and it shows an occluded cilioretinal artery. Now, this was followed by an OCT macula, which showed a retinal nerve fiber layer edema. Here, oh, sorry, retinal nerve fiber layer edema, and it shows flattening of the foveal contour. So, we safely arrived at a diagnosis of isolated idiopathic cilioretinal artery occlusion after ruling out all other causes of vasculitis and systemic abnormalities. The patient was called for a follow-up 2 weeks after this, and the visual acuity was noted to be 6 by 12 partial in her left eye. The retinal edema was further resolved on fundoscopy, and now the visual field of the patient was done, which demonstrated a significant visual field effect, as shown here. Yes, it's an inferior defect. The patient was given a maintenance treatment of dorzolamide eye drops, twice daily dosage again, and tablet clopidogrel and aspirin in once daily dosage. Now, the main goal in this patient was to prevent the further loss of vision in the same eye as well as a future attack in the same eye. So, cilioretinal artery occlusion itself is not a very common event, as only 32% of the people normally have a cilioretinal artery, and the occlusions are almost 5 to 7% of all the retinal arterial occlusions noted. It is usually associated with any other systemic diseases, which include migraines, SLE, antiphospholipid antibody syndromes, and etc. Now, it occurs as three clinical entities basically. The isolated cilioretinal artery obstruction occurs in 40% of the cases, which was our case basically. It has the best prognosis among all the clinical variants, as 90% of the eyes they return to 6/12 vision, out of which 60% come back to 6/6 vision. Now, cilioretinal artery obstruction, which is noted with a central retinal vein obstruction, occurs also in about 40% of the patients, and it also has a better prognosis because 70% of the eyes they also return to 6/12 vision. The obstruction in this case is secondary to the optic disc swelling, which occurs due to the central retinal vein obstruction. Now, the third clinical entity, which occurs in only 15% of the patient, is cilioretinal artery obstruction, which occurs with ischemic optic neuropathy or giant ciliateritis. It has the worst prognosis as most of the patients do not have almost no perception of light. Now, the mainstay of treatment to treat this is usually hyperbaric oxygen therapy, but unfortunately, we were not able to give this to our patient as hyperbaric oxygen chambers are not available in most of the hospitals in Pakistan. But it is the mainstay of treatment abroad, and it should be applied until recanalization of the retinal artery occurs. Otherwise, irreversible retinal damage can occur within 240 minutes after the occlusive events, as oxygen consumption of the retina is about 13 milliliter per 100 gram per minute, and it's highest in the body. So it's better if we provide oxygen therapy so recanalization of the artery can occur. So reduction of the IOP may also increase the retinal artery perfusion. So many strategies have been employed by surgeons to increase the retinal artery perfusion, which may include massage, anterior chamber paracentesis, and reduction of the IOP generally by any agents like mannitol or even intraocular drops. Thank you for your time. No, not at all. She was only 13-year-old, so there was no such history.
that. She was a perfectly normal child, never had any rub with Kaptan at all. So yes, that was all we could think of. Any more questions?
Good. It is worth publishing. But I would like to highlight we should have a catchy title. See, in the beginning, in the first slide, you showed case presentation. I would sort of admire the first presenter. She had a very attractive title of the presentation. See, so you make a unique sort of title so that people remember your presentation. So whenever you present or publish, try to have an attractive title.
No, thank you.
What was your rationale of using long-term beta blocker as a combination therapy?
Sir, beta block.
वो dorzolamide
हाँ जी 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 जी. Sir, dorzolamide that was to reduce intraocular pressure.
to how much like long-term is she on some
No, sir. That was only for like 2 months. Yes, 2 months.
What about the anti-clotting program?
That
Was
was
it
all.
continued?
No, that was continued for like 3 to 4 months, and then it was discontinued because no other event was noted. So she was under care of cardiovascular department as well because the lipid profile was borderline.
ये इसको लॉन्ग टर्म आप ब्लड थिनर्स में रखेंगे एज अ प्रोफिलैक्सिस और नो?
So not really because she's very young and very.
diagnosis or a working diagnosis cardiologist what it
Sir, they are keeping an eye on her and they are getting her investigation.
diagnosis idiopathic vasculitis
But they could not find any positive investigation or any neurological profile.
items देखते हैं लेकिन back of the mind में होता तो ये नहीं autoimmune disease है कुछ ऐसे नहीं पड़ी लेकिन कई बार वो इनिशियली नहीं होता है कि years to come आप दोबारा करते हैं तो फिर कोई ना चीजें आ जाती हैं उनके ब्रेन में कुछ होगा जिसकी वजह से idiopathic
उन्होंने कोई कमेंट नहीं किया बट वो ये कि रेगुलर इन्वेस्टिगेशन एंड अंडर ऑब्जर्वेशन.
लेकिन आपके पेशेंट की वीडियो रिकवरी बड़ी रिमार्केबल है. I'm very
Yes, it
surprised.
was. Yes, it was. And
what to her around the face can't find anything
thank you.
So with this, the presentations from the trainees are finished, and now I would like to invite Dr. Khwaja Khalid Shoaib, who is our national guest speaker, and he will deliver his lecture on management of superior oblique palsy, surgical management.
Hello everyone. Hello everyone. I am Josh Rocha. I'm from Brazil and I'd like to thank the organized committee to invite me for this distinguished meeting. And today I'm going to talk about new concepts on venous occlusion. I have not disclosed concerning this topic. And venous occlusion. Venous occlusion was first described 150 years ago and still today was not very clear the pathophysiology of this very important disease. It's the second most frequently vascular disease in the eye. Only to remember the anatomy, the vein and the artery is running close inside the optic nerve. The vein is more temporal and the artery is more nasal. In the Heidi's theory, the thrombus close the lamina cribosa can cause more severe venous occlusion. In branch vein occlusion, in 90% of the case, we have the artery crossing the vein over knees, and this compression maybe is the cause of the flow turbulence and the thrombosis inside the vein. And questions. What does cause venous occlusion? Thrombus, local versus systemic factors, inflammatory factors, structural or anatomic, multifactorial, and others. Now we have the Virchow theory. If you have damage in the endothelium, you have the turbulence in the flow, and this will gonna cause the thrombosis inside the vein. In this histopathology slide, you can see that the artery and the vein is very close inside the eye. Now we're gonna go 20 years ago. We have this technique for treat venous occlusion, the neurotomy. Neurotomy was first described by Mitchell Operenkach, and he published this paper with 11 consecutive cases. That the theory is release the pressure of compartment syndrome, and this can cause better venous flow. And the first paper, he had 72% of the patients gain 5 letters. After that, in this elegant editorial, Cheryl Fakehart and Kate Schuller just questions if only the vitrectomy with remove of posterior hyaloid and remove all the cytokine like VEGF is the cause of improvement in the neurotomy. After that, we have the anti-VEGF and steroid era that we live now. But in this retained study, we proved that after 48 months injecting the venous occlusion, 56% of the patients still need injections. It's a big burden. And some questions about venous occlusion. Does the mechanical compression of venous lumen induce the RVO? Does the affect vein always become thrombosed in the eye with RVO? Why is BRVO sometimes resolved by itself? Why do young patients without atherosclerosis or dyslipidemia develop RVO? Why do we hardly find the thrombus in histopathology of CRVO patients? We have some papers that uh, explain better this deregulation of the vein and the thrombus of this vein. And this might explain a little more the physiopathology of venous occlusion. What is the endothelin, this new cytokine? It's a potent vasoconstrictor, induce growth and migration of cells, regulates blood-retinal barrier, produced by endothelial cells physiologically, but can be produced by any other cells in the pathological fashion. Here, this slide can show you the proximity between artery and vein. In physiological system, the artery produces some endothelin and vein produce some endothelin. They exchange. But when we have the damage in the artery, in the arteriosclerosis, hypertension, this endothelin is much more produced in high quantity by the artery, and not only by endothelium, but the muscles and all the glial and others histological tissue surround the vein. And this data has shown us after inject in pig eyes endothelin in the vein, after 5 minutes, we have 90% constriction of the vein. That's really caused venous occlusion. And this very nice paper was published last year in Retina, and this has shown the endothelin inside the blood. In the control eyes, the level, physiological level, is much less than if you compare with patients with venous occlusion. And then, what I can tell you, vein dysregulation may be one of the cause of retinal vein occlusion. Endothelin induces retinal vein dysregulation. That what means dysregulation? We have a vein with constriction and we have turbulence in the flow, and this dysregulation can finally finish with thrombus, but it's not necessary to have a thrombus to have venous occlusion. Just need to slow the flow, and with this low flow we have hypoxia and all the disease started. And we need a new drug to treat RVO. Maybe combination of anti-VEGF and anti-endothelin can solve the majority of the problem. Thank you so much to invite me for this distinguished meeting. I'm very honored to be here and very happy to have a chance one day to visit Pakistan, a beautiful country with marvelous people. Thank you so much.
प्रोजेक्टर नहीं चला अभी उनका बंदा भी है वो बंदा वो सैम वो बैठे हैं साथ उनको वो पीछे बैठे हैं ऑन कर रहे हैं अच्छा चलो बस ठीक है सर ज़रा 2 मिनट का ब्रेक लेके कीजिएगा हाँ जी ये सिस्टम मेरा थोड़ा सा मसला कर
So, Bismillahirrahmanirrahim, I will be dealing with the management of the superior oblique palsy, only the practical aspects. See, we encounter superior oblique palsy in children, if it is a case of congenital palsy, or in acquired cases, the most common cause is closed head trauma. It may be because of the vascular problems, but rarely. So the presentation in children is usually with torticollis, abnormal head posture. You see, there are three elements of abnormal head posture. One is head tilt like this. The other is face turn like this. And the third is chin elevation or depression. And the patient presents with chin depression so that the eyes are in the upper portion of the palpebral fissure. So head tilt, face turn and chin depression. The adults usually present with diplopia. So they are aware of the diplopia, and you see, this is a video, if we can run it. The patient is having left hypertropia, and with biopsy three-step test we will confirm that it is a case of superior oblique palsy. It increases in the contralateral gaze in the right gaze, and when you tilt the head to the left, the hypertrophy of the left eye increases. So this confirms the superior oblique palsy. Now, just to diagnose the case, this is right hypertrophy. These four muscles are responsible, increasing in the left gaze. So these. And increasing in the on the right head tilt. So this is the muscle in which the three circles overlap, and this gives us the diagnosis. And this we have to draw it in every vertical muscle palsy, vertical diplopia. So the past three-step test actually is 70% sensitive and 50% specific, because of the other reasons. I will not go into details. And in unilateral palsy, there is less of X cyclotorsion and no V pattern, but in bilateral cases, the X cyclotorsion is more than 20 degrees. The difference between a congenital and acquired palsy is that in congenital cases, the vertical fuel reserves are more. It's more than 3 degrees. So if there is an MCQ that how will you differentiate between a congenital and acquired palsy, you will answer by measuring the vertical fusion range. Okay, so diplopia charting is a very easy way. You can do it with red and green glasses, and you have to keep the source of light in a horizontal slit. You see, this is a lateral rectus palsy. So if I am a patient, you will keep the object like this, and you will ask the patient in which direction of gaze the diplopia is maximum, here or here. But if you are plotting the diplopia imaging for vertical squint, then you will keep the object like this, and you will ask whether it is more here or here. So in superior oblique palsy, let's say I have a left superior oblique palsy. This is the position, dextro depression, where the superior oblique should be functioning. It's not functioning, it is paralysis. So the maximum distance between the two images will be in dextro depression in case of the left superior oblique palsy. You see, the distance between the two images will be maximum here, but the tilt, that is the angulation of the image, will be maximum in this direction. So the secondary action, the intorsion, is maximum at 90 degree to the primary action. So you have to keep these things in mind. So vertical diplopia we will keep, if you see, this is the position the dextro depression, where there will be maximum separation of the two images, and at 90 degrees this will be the position where the angulation will be maximum. So with this diplopia charting we can diagnose the sphenoblique palsy. But to document it, how much it is, we have to use the Maddox rod, keep it vertical, and the patient will see a red line. If it is above or below, will tell hyperphoria or hypertropia. Now, how to document the cyclotorsion? You can see the fundus, and if the fovea is below the lower tip of the optic disc, then the patient is having X cyclotorsion. You see, the superior oblique is in daughter, and its palsy will result into X cyclotorsion. The fovea will be below the level of the lower margin of the optic disc. And now the inferior oblique weakening has been done, and it has come back to normal. The normal position of the fovea is that it is at a level between the center and the lower tip of the optic disc. So you can do the indirect ophthalmoscopy, it will tell you a cyclotorsion. You can do fundus photography. You can do blind spot mapping on the perimetry or iris photography, and you can document the X cyclotorsion. Now this is the double Maddox test. You have a white and red goggles, and so we place two Maddox rods, one red and one white, and place a source of light. The patient will see two lines. So I will skip that video, and the patient will see like this, and you will ask the patient to align the two lines, and the degree of rotation of this dial will give you how much of the X cyclotorsion is present. So you can easily measure the X cyclotorsion with double Maddox rod test. So you can measure it with synaptophore, and Maddox weighing has chart, Lee's chart, Lancaster video goggles. These are all different methods of measuring the X cyclotorsion. Now coming straight away to what we should do when we encounter a case of superior oblique palsy. Now this is if the hyperdeviation is worse in contralateral up gaze, we have to do weakening of the antagonist. Suppose my left superior oblique is paralyzed. If the vertical deviation is more here, which is the muscle which is moving the eye up, is inferior oblique. So we will do inferior oblique recession of the left eye. If the hyperdeviation is more in the down gaze, let's say left superior oblique palsy, vertical deviation is more in the dextro depression, it means that the left superior oblique is not functioning, so we will reinforce it by superior oblique tucking. So superior oblique tucking if the superior oblique is lax. Now we will show you the diagrams how the indications are there. So if there is hypertropia, we will do one muscle surgery. If the hypertropia is more, 2 or 3 muscle surgery. So this is superior oblique tucking. So we lift the superior oblique above the eyeball. If you can pull it 10 millimeter above, it means superior oblique is relaxed. So you hook it, so you have hooked it and clamped it, and you apply the sutures here. So this is the muscle has been hooked, and so superior oblique tucking or plication will improve the strength of the superior oblique. If the X cyclotorsion is more, patient is having a head tilt more, then you do a Harada-Ito procedure in which you split the superior oblique and transpose the anterior half, bring it close to the lateral rectus anteriorly and laterally, and this will correct the cyclotorsion. Now, if inferior oblique is sort of working above the normal level, then you have to do a weakening procedure. There are many procedures for inferior oblique weakening, but I will only explain the recession, transposition and myectomy all these are not done anymore because of the inferior results. So this was the patient who came to my clinic with this posture. He entered my office like this. So he had trauma and developed sphere oblique palsy, and he was having abnormal head posture with head tilt and face turn and chin depression. And this is after inferior oblique myectomy. You see his posture has improved. You can see the right hypertrophy, and right hypertrophy increases on the right head tilt and on the left gaze. So again, this child entered my office with face like this. He was moving about. Abnormal head posture due to eye reason is called ocular torticollis. And if it is because of the sternomastoid, this is non-ocular torticollis. So this again hypertrophy corrected by inferior oblique myectomy and inferior rectus recession. So these are the different procedures. This is the normal inferior oblique. If you sort of stitch it here, this is recession. If you bring it forward, this is temporal transposition. If you bring it towards the nasal side of the inferior rectus, this is nasal transposition. So these are a few operations of inferior oblique. So this is, if I can run that. So we approach the inferior oblique by 10 to 12 millimeter from the limbus, make a radial incision, engage the inferior oblique, and we remove 5 to 10 millimeter of the inferior oblique muscle, and this is called inferior oblique myectomy. See, in recession, we bring the attachment of the inferior oblique from lateral rectus position to close to inferior rectus position. This is for +1, +2, and +3. So now we are doing more of inferior oblique recession than myectomy procedure. So again, you see this is a case of left hypertrophy, which has been corrected by anterior transposition. You can appreciate the left inferior oblique overaction, which has been corrected by anterior transposition. So in this case, inferior oblique overaction was combined with DVD. Under cover, the left eye is going up, and this has been corrected. So if you remember this, the inferior oblique is passing 4 millimeter behind the inferior rectus insertion. So if you bring the inferior oblique forward, this is called anterior transposition. If you bring it close to the inferior rectus insertion, this is called 0 position, this is +2 position, and this is -2 position. In any case, the inferior oblique is brought in front of its normal position. So if I can run this. So this is, we have isolated the inferior oblique past the sutures, and then we stitch it on the nasal side of the inferior rectus. Okay, thank you very much. Any question or comment? Just to summarize, I have done about 100 cases of inferior oblique weakening procedure. About 1/3 I did myectomies, 1/3 I did inferior rectus, inferior oblique recessions, and about 30 cases of inferior oblique anterior transposition. So these 3 procedures all are acceptable in their own respect. Any questions?
So what is your percentage of getting resolution of vertical diplopia and dorsal diplopia in your surgery?
90-95%. You see, I showed you the patient's head posture is corrected. When the head posture is corrected, diplopia. So the abnormal head posture is there to avoid diplopia.
But do the patients presented with diplopia?
Yes.
Or they were diplopia compensated by or resolved by head posture?
Actually, they can present in either way.
So the ones you operated were which ones?
The children usually present with abnormal head posture, while the adults mostly present with diplopia. The children cannot express the diplopia, so they learn how to avoid it. But the adults are specific in mentioning that if I turn like this or this, then diplopia increases.
So by anteriorizing the fibers, you're just getting rid of that.
Yeah, the anterior nasal transposition is, I do it if there is inferior oblique overaction, so to weaken the inferior oblique, and if there is also DVD present, then I do anterior nasal transposition. Otherwise, I will do recession if there is only inferior oblique overaction. See, inferior oblique recession is better procedure because we can calibrate it. +1 inferior oblique overaction, +2, +3, and we have different positions for the correction. Myectomy is a simpler procedure. For the newcomers, I would suggest them to start inferior oblique myectomy and later on shift to inferior oblique recession. But if there is also DVD, then we will do anterior nasal transposition.
Very impressive. What was the etiology? If you take a band of etiological causes, so out of these 100 cases, what was the etiological sort of factors?
In children, we can't be sure what is the cause of congenital fold nerve palsy, but in adults, the commonest cause is trauma. The patient tells that he had a fall from, let's say, horse or while riding a bike, and then suddenly he developed diplopia. So trauma is the commonest cause of fourth nerve palsy. You remember that for third nerve and sixth nerve, the diabetes and hypertension are the commonest cause. But for fourth nerve, trauma is number 1 and diabetes and hypertension are number 2 causes.
So residents, what stabilizes for the residents? What stabilizes for the residents? It's a masterly presentation by Dr. Khalid. How is the inferior oblique working after inferior oblique myectomy? You don't release it to the extent that it just slips back into the orbit. So how does it actually come to a new insertion after myectomy? ये PGs के लिए. But PGs, I'm impressed now because सारे PGs are very intelligent.
Make us more proud then.
See, the previously used technique was myotomy, which inferior oblique was simply cut. But the problem was that the two ends would join together and there would be recurrence of inferior oblique overaction. So that's why they have shifted to myectomy, where you make an incision here and an incision here, and 5 to 10 millimeter of the inferior oblique is removed, excised, so that the two ends do not join again and there is no recurrence. So this is myectomy, where you don't touch the insertion and origin, you just take away the central 5 to 10 millimeter of the muscle.
You do more of myectomy?
No, initially I used to do myectomy because it's a simpler procedure. Inferior resection, inferior oblique resection is one step sort of more advanced, where you place the insertion at a specific level.
Do you do an adjustable suture or do you do fixed suture?
Fixed suture I do mostly because it is very predictable. You know how much is the inferior oblique overaction and you plan accordingly.
With myectomy, basic problem is they get problem elevation. They don't go very high because.
So we usually do myectomy in inferior oblique overaction +3 or +4 type of thing. When it is marked, when it is slight, myectomy is usually not done. Thank you very much.
Thank you very much, Professor Khalid Shoaib, for a very, very excellent presentation regarding surgical management of superior oblique palsy. Most of these points which were highlighted in the management, they will also help all our trainees to just correlate these things, and in your examination these all points will help you. With this presentation part is ended. Now I would like to call on Professor Moeen, who is President of OSP Lahore, to say a few words, his concluding remarks, and then we will present the certificates to the trainees who have presented.
Assalamu alaikum. Thank you very much for holding this event at Sheikh Zayed Hospital. It's very good to see Professor Hamid. He's worked here as a resident only, or
yes,
not at the head of the department?
Well, as a resident, senior registrar, system specialist.
Right, and thank you, Professor Salim Akhtar, for joining us, and thank you very much for hosting the event. And the clinic, it's very good to see all of you sitting here, and I think you started your cataract surgery, your machine has arrived, the Oatly machine, congratulations. Long term. Sheikh Zayed, that's a big achievement, I think, over the years for you, because you had to struggle a lot with the administration to get your...
More good news coming because the PC1 will almost finalize. We will be getting more.
So more machines will be coming up. So Sheikh Zayed, well, you've got your own medical college and you got your... So इसमें आपको medical students भी बैठे हैं या इस वक्त ज़्यादा वही हैं PGs हैं? Medical students भी हैं. So it is very good. I think it's a very good place. Whenever you come, आपको लगता नहीं है कि probably लाहौर में किसी सरकारी अस्पताल में आ रहे हैं. So it gives you a good impression. So OSP always tries to continue with its clinical meetings. In the clinical meetings, the main aim is to refresh knowledge and give the opportunity for the residents to come here and present and to get involved in question answers to make it easier for them to go forward in the research, and it gives them an advantage that the papers they have presented, they're confident that they might even be considered as posters, or they can be published as papers. So posters or presenting at a meeting is very good. That probably gives you an assessment of how good or how bad your clinical work is. So you should keep doing it internationally as well, because we were there at the APO meeting. There were a lot of presentations and everything. From India was a lot, but and other countries were missing. So we'd encourage कि जो आपको लगता है it is good, you should always, अगर आप नहीं भी जा रहे तो if your supervisor is going, you can include his name, he can do that, and that will give us a platform in which OSP can be represented across internationally as well. We are going to have a Lahore annual meeting is 6 to 8 December, and we are planning to have, probably if things go right, the Asia Pacific Trauma Association, their satellite meeting to be held with that. So we'll encourage you to start working on your presentation. The abstract submission is open for that. So it's easier. अगर आपका कुछ लगता है जैसा कोई cases है, एक तो grand clinical round में इनका जो आपकी best result आएगा, that will go into a grand clinical session at the OSP meeting as well. But otherwise, if you have your research, you should publish, or you should at least present in the meeting, and keep doing that, so that as you climb the ladder, you will be more addressed to what you should be doing and what is your direction which you need to be going. Thank you very much again, and probably there are some bouquets to present, and we'll ask first Professor Khaja Khalid Shoaib to come and receive, because he's the national speaker. Second bouquet we want to be presented, sir. Idhar hi the guest, the host organization from OSP to the host, Professor Atif ke liye, I'll ask, also request Professor Hamid to come in and. Now I request Professor Khwaja Khalid Shoaib to come in and announce the result of the presentations.
Okay, so very well prepared and presented. I congratulate all the presenters for excellent scientific material. There are very minor differences, so it was very difficult to decide who is first and second. But the panel of judges has decided, so we will go accordingly. Dr. Mualla has got third position. Please come here and take Dr. Khadija Junaid has secured second position. So, second position is being shared by Dr. Noor Fatma also. So, congratulations. Sorry. And the additional marks for wolf in sheep's clothing. Well done, Dr. Noor Tariq. First position. Barrett Hodgson.
Hodgson.
जी आगे Rashid साहब आगे. So Rashid साहब is always there whenever we require him. So thank you very much for all their money.
As a host department, we are very thankful to the Director Hudson Pharma for facilitating the event next.
Now नहीं सुना मैंने. Hमेशा positive. वो मेरा. नहीं.
Sir, last. आपको
So, on the behalf of Department of Ophthalmology, Sheikh Zayed Hospital, I thank you all the audience for a very patient listening. Hope you have found these cases interesting and looking forward to your participation in your own respective departments in these OSP clinical meetings and hope to see more meetings. I just want request Professor Hamid Batsab to please come and say a few words. So you need mic? Mic bill.
I think it's a very, very proud privilege for me after the President has spoken and the Chairman Department of Ophthalmology, King Edward Medical University, Professor Salim Akhtar, Khwaja Khalid Shoaib Sahab, the Honorable Suhail Taiba. I feel very proud today because on this rostrum I have been presenting as a resident. So I see a lot of enthusiasm and a lot of trust in the trainees who have presented the cases here. I'm very, very pleased to see their confidence and I'm very pleased to see their presentations and their grit. And I'm sure that the future, our future, is secure because of you. Some of you could be operating on us. And at the same time, I feel very proud that Professor Atif is holding the torch so well we had I take this opportunity to remember my illustrious teachers and mentors, Professor Jahangir Durrani Sahab, who was an American born, who actually हमारे साथ बैठ के, he used to assist me on the side of the microscope when I was operating, and I tried to carry that tradition with my trainees also, and also remembering the great Professor Iftikharul Haq Qureshi Sahab, because I had the best of two American ophthalmology and the British ophthalmology. Each of them actually had spent 20-25 years of their life. They landed here. I was only part one with them at that time. और हम कहते होते थे part one, वाइवे वाला part one. So I'm very, very proud. Thank you very much for giving me this opportunity. President साहब से इजाज़त के साथ. Thank you, thank you, Mr. President.
I want to introduce के आप लोगों ने नई चीज सुनी हो, work based assessment in CPS में सुन रहे हैं ना? He is the mastermind behind it, and I'd like to congratulate him for implementing his idea. His dream was to get WBA incorporated in the CPSB curriculum. So we had a meeting with international educationists as well at CPSB Karachi, and finally it has been launched. So it is nothing to be afraid of. It is just simply like having a short case and a long case in your clinical rotation, so that you can ask your supervisors to judge it, and you can be assessed on those same things on a rubric, and that will give you an easy preparation for your exams as well. And the other skill is the surgical skills. That is an improvement on your clinical skills. So that is something, if you have, it will obviously make you a better surgeon when you're an accomplished surgeon when you come out of your residency program.
Thank you. I think Carl Golnick was the man who is, अगर आप punch करें, Carl Golnick, so he's an international medical educationist and trainer. And the reference in neuroophthalmology that he actually, we had a strategic meeting with him in Karachi CPSB, and I would take this opportunity to also pass on the baton to Khaja Khalid Sahab. He's the superior oblique man here. He's the faculty secretary now, and Professor Mir Ali Shah is the dean of the faculty. I was the dean of the faculty for 4 years from 2010 to 2014 CPSP. तो कहने का मतलब ये है कि ट्रेनिंग प्रोग्राम्स भी अब स्ट्रक्चर्ड हैं, जैसे एमसीक्यू और टॉक्स के स्टेशंस हैं, तो ट्रेनिंग के स्टेशंस भी आपके 4 ईयर के अंदर स्ट्रक्चर करके आपके साथ शेयर किए जाएंगे, ताकि आपको शॉर्ट केस देखना, लॉन्ग केस देखना, surgical skills especially in a surgical rubric. So things are on the mend, things are improving, and I'm very proud to be here with you. Thank you for giving me the opportunity.
Thank you. Can I just share with you an experience? Professor said that we train you with the confidence that you can operate on our eyes if required tomorrow. I am a witness to it. I was operated by my own house surgeon. Excellent surgeon, excellent results. But obviously I was wearing glasses before, I'm still wearing, that's none of his fault. I was made like that. But that is the confidence. The day I needed surgery, he checked me, he did whatever was the routine thing, and he said, sir, what technique would you like me to do your surgery with? I said, don't ask me, do what you feel better. Treat me as an ordinary patient and tell me what I'm supposed to do. And that was it. So we are training you for tomorrow, so that you can operate our eyes. Well, mine has been done, hopefully. But there are still plenty around. So don't be shy if you want, when you are being taught. Don't be shy if there is something you have not understood it. As I said, all your teachers are there. I have been doing the same, Ahmed Saab has been doing, and so is everybody doing. Sit on the assistant piece myself and assist the operator, and that is actually an investment for our future. So don't be shy of it. If you ever feel that you have got some trouble somewhere, ask it. They are sitting there to help you. and they will be very glad to help you. Good luck.
Thank you very much, sir, for your worthy comments. I'm honored to have all my senior colleagues giving their feedback and input. And now, with the end of this session today, I would invite all of you for a lunch, hopefully sumptuous one, and I will lead you to the dining hall.